Hello, and thank you for joining this Pharmacy Times peer exchange titled Expert Perspectives on Diagnosis and Treatment of Irritable Bowel Syndrome. Irritable bowel syndrome is a functional gastrointestinal disorder affecting an estimated 1 in 6 people in the United States. Symptoms are variable and can range from mild to severe, but IBS is a long-term condition, so symptoms may come and go and change over time. In this peer exchange panel discussion, I'm joined by my colleagues who are experts in irritable bowel syndrome. We will review the causes, diagnostic workup, management, and even emerging therapies. I'm Dr. Mark Pimentel, Executive Director of the Medically Associated Science and Technology Program at Cedars-Sinai in Los Angeles. Participating today on our distinguished panel are Dr. Bill Che, Professor of Medicine and Nutrition and a gastroenterologist at the University of Michigan in Ann Arbor, Michigan. Also joining me is Dr. Tony Lembo, Professor of Medicine at Harvard Medical School and Director of the GI Motility Laboratory at Beth Israel Deaconess Medical Center, Division of Gastroenterology in Boston, Massachusetts. On my right, Dr. Ali Rezai, Medical Director of the GI Motility Program and Director of Bioinformatics at the MAST program at Cedars-Sinai in Los Angeles. And finally, Dr. Brennan Spiegel, Professor of Medicine and Public Health and Director of Health Services Research at Cedars-Sinai Health System in Los Angeles, California. Thanks so much for joining us, and so let's begin. So the first part, we're going to talk about understanding irritable bowel syndrome. And so what is IBS? And I know that seems like a very simplistic question, but it's really not. Tony, can you take a crack at what is IBS and how do you sort of define it?
Sure. Well, in the clinic, most patients who present with IBS have pretty typical symptoms. In fact, they always have abdominal pain as one of the distinguishing characteristics of IBS. It typically is a crampy pain, most often in the left lower quadrant, but can involve any part of the belly. But it has to be associated with some change in bowel habits. So either it gets worse or better with a bowel movement or immediately after a bowel movement. And typically, or with a change in the stool consistency or in the form of the stool. There are other symptoms that are commonly associated with IBS. So patients frequently present with abdominal bloating, urgency, and the stools can either be hard or loose, and sometimes they can vary in the same bowel movement. The patients can alternate between diarrhea and constipation. So there are several subtypes of IBS, and they're based on stool characteristics. So we have IBS with constipation, and those patients typically have hard stools that can be difficult to pass. Or we have IBS with diarrhea, when stools are loose, frequent, typically associated with urgency, or IBS mixed, where they go back and forth between diarrhea and constipation. And sometimes patients will fall in the middle and won't be classified. But the majority of people are IBS C, D, or M, and we'll talk more about this as this program goes on.
But some of the definitions have changed over time, Brennan. I mean, it's a little confusing for some people because the Rome criteria change. What's evolving in IBS, and where are we contemporaneously to now? Is there a change in the definition with Rome 4? Maybe Bill can chime in on that also.
Yeah, I mean, every few years some of us go to Rome and we have a good time, we eat some pasta, and then we come down with some new criteria. But, the human body doesn't know that we're coming up with new definitions for what it does. It just sort of keeps doing what it's doing. So I think it's important to have these definitions for academic purposes, for clinical trials, for example. But really in the clinic, what Tony said is essentially right. I mean, exactly right. I mean, not essentially, right? The idea is that you're looking for people who have recurrent abdominal pain or discomfort with abnormalities in stool frequency or form. And importantly, who don't have alarm features, who aren't, losing weight without trying, who aren't passing blood in their stool. These are signs that we call alarm signs that would suggest maybe another diagnosis before we're willing to make a diagnosis of IBS. But over the years, there's been many different definitions, and honestly, I don't even think gastroenterologists have a clear handle on exactly how the definitions have evolved. So I think that's less important clinically than just understanding the basic phenotype, and as we'll get into, what diagnostic tests may or may not be important.
The thing that confuses me the most about any of the criteria we have for IBS is the definition of pain. Because How often should it be 5 minutes a day? Does that qualify as a pain today? Should it be an hour? Should it be 5 out of 10? I mean, for the clinician, for practical purposes, how do you use that particular symptom, Bill?
Well, the first thing to say is before we talk about clinical practice, and just to clarify, you know, the Rome criteria were originally developed as research criteria because we needed a common language to identify patients for clinical trials. And we do go to Rome and eat pasta and drink wine, but honestly, it's a comprehensive 5-year process to develop these criteria. And you know, I don't want people to leave with the impression that you know, we just sort of sit around a table and sort of make this stuff up. No, it really is an evidence-based 5-year process to get to this product. But I agree with all the comments that have been made, which are that in real life, we're really probably not focusing on the Rome criteria. We're really focusing on the presence of abdominal pain and altered bowel habits. And as to your specific question, Mark, the bottom line is that what's meaningful to the patient. If they're having problems for 5 minutes, but it's interfering with their ability to carry out their daily activities, to me, that's meaningful.